Hello, my name is Deb Smith. I'm an Improvement Consultant at Health Quality Innovators, or HQI. This educational event has been developed in partnership with HQI, the Virginia Department of Health, and the Virginia Hospital and Healthcare Association. I would like to draw your attention to the icons at the bottom of your screen. There are two green icons to the right. One is for the resources for this education, and the other is for the post-test that you will be taking after completing the education. Take a minute to review and download the resources. After reviewing this pre-work, you will be ready to view the recorded education. On completion of the recorded education, you will need to take the post-test. You'll have two chances to achieve a 70% or higher in order to receive your certificate for credit. I would now like to introduce your instructor for today. Dr. Mike Stevens is an Associate Professor of Internal Medicine at Virginia Commonwealth University, where he is also an Associate Hospital Epidemiologist, the Director of the Medical Center's Antimicrobial Stewardship Program, and an Associate Program Director for the Internal Medicine Residency Program, where he is also the Global Health and Health Disparities Pathway Director. He is also in the Director of the Medical Center's Travel and Tropical Medicine Clinic. Dr. Stevens, the floor is yours.
Thank you for that kind introduction, and I'm excited to be here today. I want to thank Health Quality Innovators for putting together the slide deck and inviting me to come and speak. Also, thanks to the Virginia Department of Health, as well as the Virginia Hospital and Healthcare Association and the Virginia Healthcare Associated Infections Advisory Group. I have directed the Antimicrobial Stewardship Program at Virginia Commonwealth University since 2010. I have no disclosures, and of course all of this is my own opinion, what I'm saying over top of these great slides. So for the objectives, we're going to define antimicrobial stewardship. We're going to talk about the benefits of having an antimicrobial stewardship program. We're going to review guideline recommendations for implementing a stewardship program, describe antimicrobial stewardship strategies in the hospital setting, and also highlight specific initiatives to meet new regulatory requirements. Traditionally, cost-controlling arguments for antimicrobials have been proposed to justify ASP resources. Focusing on antimicrobial costs is dangerous because there are natural limits to cost containment. However, the mandates for stewardship, which we'll discuss later in the slides, are a boon to programs arguing for resources because business models can be proposed based on potential reimbursement penalties associated with the new mandate. So I strongly encourage folks that are creating stewardship programs and arguing for resources, for justification of resources, to not do a traditional cost model based on expenditures for specific antimicrobials, but really to look at the new mandates as a potential way to create a new business model. But beyond costs, arguments for resources should be made based on patient safety, reducing the emergence of antibiotic resistance, and improving the safe and optimal use of antibiotics. And we'll talk more about that. So again, stewardship in a nutshell is focused on two overarching concepts. One is reducing the emergence of antibiotic resistance, and two, improving the optimal use of antibiotics. Now, there are multiple different strategies that programs can deploy. The two primary strategies are, number one, antibiotic restriction, which essentially is people have to call for approval for certain agents, and if they don't meet use criteria, they are not allowed to use those agents, so restriction. And then number two is review of pre-existing antibiotic orders to assess for opportunities to improve antibiotic use and de-escalate. Now, by improve antibiotic use, sometimes this is not going to a narrow spectrum antibiotic or stopping antibiotics, but it's actually escalating therapy or starting an antibiotic. So that's an important concept, and we'll touch base on that a little bit more. Other important strategies that are supplemental to these core strategies include things like review of pre-existing antibiotic orders to optimize dosing, especially for narrow therapeutic index drugs like gentamicin, and again, those opportunities to improve use that really don't involve de-escalation. An example of that might be somebody with fungemia not on an antifungal starting a drug in that scenario. So these are all examples, and there'll be multiple examples throughout this presentation as we go through. Other important stewardship activities include monitoring and reporting out of process and outcome metrics. Examples of some of these would be antibiotic prescriptions or prescribing, total antibiotic use, number of interventions, the emergence of resistance, amongst other things. So now, when we talk about how to do stewardship, the CDC has released core elements of stewardship for hospitals, nursing homes, and outpatient facilities. And mandates really parallel these recommendations. So these are very important, and these are things that surveyors and others who are assessing stewardship programs will be looking for. So the core elements for hospitals and nursing homes really involve a leadership commitment, so there should be somebody who's accountable for the program and for program outcomes. Ideally, this is a physician with some advanced antibiotic training or infectious disease training, as well as a designated pharmacy leader. Again, that accountability goes back to identifying leaders within the program. A step back, that leadership commitment has to be at the highest level of the hospital, dedicating resources to stewardship programs. Drug expertise for the people who are running the stewardship program. Action, we'll talk about what actions are within stewardship programs throughout the deck here, but this is actually doing active stewardship, having a program that's active, tracking the process and outcomes of the program, and reporting these out in the appropriate committees within the hospital, but then also to frontline providers, and then doing education, usually tied to other interventions or other activities of the stewardship program. Now, when we look at the core elements in the outpatient arena, essentially they parallel the inpatient core elements, so I'm not going to go through those in great detail. You can see those on the slide. Now, I will say there's an important, because every setting is different, the resources in every setting are different, but these core elements really are similar no matter what the setting you're in. Not every program is going to adopt all of the same strategies. The National Quality Forum released a practical playbook for stewardship programs that can serve as an a la carte menu for programs desiring to initiate a stewardship program and trying to build a program around these core elements. So again, that could be a great resource for you as you develop a program. Now, when we talk about requirements, we talk about the mandates. Joint Commission survey requirements began January 1st, 2017 for acute care settings, and CMS mandates exist for long-term care facilities. Now, conditions of participation were also proposed for acute care settings, but those are on hold for now. But the future really is a future where there will be reimbursement penalties tied to mandates for stewardship programs. And some of these things, in terms of what people will actually be held accountable for, are an evolution, but they seem to be really paralleling those core elements from the CDC. So stewardship mandates are a reality, and in my opinion, these are a major boon to programs because this will help with arguments for resources. Now, looking at a stewardship committee. So oftentimes there'll be a stewardship committee within a hospital that, although the stewardship program has a major influence and presence on, the stewardship committee will include individuals that are in that core stewardship program. Sometimes this is a freestanding committee. Sometimes it is a subcommittee of the Pharmacy and Therapeutics Committee. Ideally, you would have these folks involved on a stewardship committee. So you would have a specialty physician representing antibiotic, advanced antibiotic training. Usually this is an infectious disease physician. Pharmacy should be at the table. Nursing should be at the table. You want to involve the microbiology lab. Infection prevention and hospital epidemiology should be involved. Individuals from information technology should be involved, and then other healthcare professionals, sometimes administrators, depending on the setting, should be involved. So again, there are a number of different people who are important to have at the table because stewardship really cuts across all of these, or touches all of these specialties, disciplines, but then also is very reliant on these other departments within the hospital. And I will say one other thing here, really looking at where stewardship is going. Ideally, stewardship programs would be embedded with, or at least tightly integrated with, infection prevention programs in hospitals. They use a lot of the same techniques. They use a lot of the same technology, and their reporting structures are not dissimilar, so that you can really synergize when those two groups are working together. We talk about why stewardship matters. Well, it's been less than 80 years since the widespread adoption of antibiotics in the 1940s, and we're already talking about a post-antibiotic era. And really what we're talking about is a return to 19th century descriptions of the management of infectious diseases. So for patients with infection with pan-resistant organisms, really those organisms, especially gram-negative organisms, folks that have these resistant pathogens have a really, really very high mortality, especially if they're bacteremic. Now, if you have a infection in a limb, say a diabetic foot infection with a resistant pathogen, oftentimes the best you can do is local therapy or resection of infected tissue, sometimes amputation. Again, this management harkens back to the management of infectious diseases in the 19th century. So the post-antibiotic era very much looks like the pre-antibiotic era, and this is a reality for many of our patients now. So really this is the overarching impetus for adopting stewardship now in 2017. We'll talk a little bit more about that as we move forward. So this slide from the CDC. So when we talk about the untoward effects of antibiotics, really these compounds are not necessarily benign. In fact, antibiotics are responsible for 1 in 5 ER visits for adverse drug events, and they're the most common cause of ER visits for adverse drug events in people under the age of 18. There's a lot that's being discovered about the collateral damage of antibiotics in terms of affecting the microbiome. The grossest example of this is what happens with wiping out gut flora and then setting up a scenario where Clostridium difficile can overpopulate the gut and cause clinical illness. But there is more and more data that we're also affecting the microbiome in other parts of the body. We just don't know enough about this yet. But the collateral damage may include links to obesity, diabetes, cardiovascular disease. There's a lot that's unknown, but they are not necessarily benign compounds. We do know that antibiotic use leads to antibiotic resistance. And it's important to recognize that oftentimes when people become infected, they're becoming infected with their own flora. So an example of this would be somebody developing an E. coli urinary tract infection. That's their own population of E. coli that they acquired the infection with. Now, if somebody is given a fluoroquinolone for some reason, their normal flora, their E. coli can become resistant to that, and then that antibiotic may not be available to them when they subsequently develop an infection 3, 6, 9 months later. So antibiotic use definitely can lead to antibiotic resistance, and resistance cuts across all microorganisms. So any organism that can be affected by antimicrobials can develop resistance, and this is a problem across the board. It's with gram-positive organisms like Staph aureus, with malaria, with tuberculosis. Of particular concern in 2017 is resistance in gram-negatives, because there's a paucity of new drugs in development for these resistant gram-negative organisms. The CDC really probably is an underestimate of the total morbidity associated with antibiotic-resistant infections. So 23,000 deaths per year, over 2 million illnesses caused from antibiotic-resistant pathogens. Now, again, this is probably the tip of the iceberg because the estimates, the future estimates are much higher than this. So it's estimated by 2050 there'll be 10 million deaths per year from antibiotic-resistant infections. That's a death every 3 seconds. That's more than are projected to die from cancer in 2050, which is 8.2 million people. So this is a crisis. It's a crisis now. We're really seeing the tip of the iceberg in terms of resistance, but we need to do something, or this is only going to get worse and worse. We talk about stewardship initiatives. Talked about this a little bit earlier in the slides. The key strategies include restriction of antibiotics and then post-antibiotic order review with provider feedback. One of the things that we're looking at on this slide is antimicrobial criteria for use. And what does that mean? So essentially, for every antibiotic, but especially those that are restricted, there should be very transparent, clear criteria for use so providers know when to use the drug optimally. And they know when to call for approval, when they should not, what the alternatives are. It's very important that folks always receive guidance on what is the most optimal antibiotic to use for any specific condition. And we'll talk more about that. That really falls under the supplementary strategies. Again, those include dose optimization, the deployment of local treatment guidelines, among other key strategies. So talking a little bit more about restriction and pre-authorization. So throughout the slide deck, you're going to see numerous examples of these different restriction strategies or different strategies under the specific stewardship strategy. These are a few examples. They may or may not be appropriate for your setting. They're certainly not comprehensive. There are numerous different ways that these could be deployed depending on your setting, local resistance profiles, what are considered the key antimicrobials, and that sort of thing. So stewardship, one of the key stewardship tools, again, is restriction. Restriction is very powerful because antibiotic selective pressure really has to do with exposure to those antibiotics. If patients aren't exposed to those antibiotics, they are less likely to develop resistance. That's sort of the bottom line. So if you control the use of the agents, you're exposing people to the antibiotics only when really truly appropriate. Some examples here would be for agents that are associated with high mortality when used inappropriately, like tigecycline, things that are very narrow spectrum but potentially high cost, like daptomycin, and then things that really should be held in reserve for last resort, as last resort agents for really resistant infections, things like colistin and some of the newer drugs that are coming out that have some activity against the resistant gram-negatives. When we talk about criteria for use, again, we talked about this a little bit before. This, again, is to be transparent with when these drugs will be approved or when they should not, what the alternatives will be, but just being very clear about all of these things for frontline providers. And this really overlaps with treatment guidelines, which we'll talk more about. So some examples of criteria for use. So some folks might say for daptomycin, well, we're only going to approve this when somebody has a MRSA infection and they're failing vancomycin, or there's a high vancomycin MIC to that isolate. For linezolid, maybe only if there's worsening pneumonia secondary to MRSA that's been documented and they've already failed vancomycin. Another potential example would be using echinocandins when you have documented invasive Candida infection with things that are resistant to fluconazole. Again, these are examples. These are not meant to be the only potential ways to develop criteria for use, and these may or may not be appropriate for your setting. These are examples, again, of how you would create these within a program. When we talk about antimicrobial dosing and monitoring protocols, this is a supplementary strategy, and when I say supplementary, it doesn't mean that it's less important. It's just usually the other core strategies are adopted first. This can be very important, especially for neurotherapeutic index drugs with high potential morbidity. A prototypical example of this would be aminoglycosides, especially gentamicin. And these can be of enormous value when adopted in a comprehensive stewardship program. Oftentimes, this is being driven by the frontline work of pharmacists involved in stewardship programs. Antimicrobial dosing and monitoring protocols, again, this is an extension of the last slide. These should be available to providers and specific to the institution where appropriate and widely available. So we'll know exactly for what drug, what would be the right dosing for any given sort of category of renal insufficiency, or depending on what type of renal replacement therapy a patient is receiving. Now, talking about antimicrobial dosing and monitoring protocols, when we talk about preoperative antimicrobial prophylaxis, this really is what we call low-hanging fruit for antimicrobial stewardship programs. It can be highly complex in terms of doing this right and monitoring, are people using the right drug at the right dose at the right time and doing the right type of intraoperative redosing. However, there's potential enormous benefit to patients and to institutions in reducing surgical site infections when this is deployed correctly, and these things are all very well laid out. So the next slide really gives you an example of this from the Surgical Care Improvement Project, which really we're not talking a whole lot about anymore, but it does provide some nice guidance as to drug doses recommended for surgery. However, there's a comprehensive guideline from this by Bratzler et al. That's also available that can tell you exactly what antimicrobials to use per condition and procedure, and spells out the right dosing and intraoperative redosing. So again, these are potential major targets for stewardship programs, especially stewardship programs looking for early wins. When we talk about other supplementary strategies, one of these, again, somewhat low-hanging fruit, but with potential enormous benefit, is IV to PO switch protocols for drugs with high oral bioavailability. These can be done in a relatively simple fashion, but automated at the level of the pharmacy once these protocols have been adopted locally. And then when we talk about local treatment guidelines, these can be of enormous utility to providers. And what I will say here is, really, stewardship programs should partner with frontline providers wherever and whenever possible, and should be viewed as an asset in the optimal treatment and approach to infectious diseases in these patients. One of the ways stewardship programs can avail themselves to frontline providers is to create things that make their lives easier. Everyone's trying to do the right thing in terms of addressing these infectious diseases, and people love local treatment guidelines. Now, the value of these over national guidelines is that they can actually account for local antibiotic resistance via the local antibiogram. We'll talk about that in a slide or two. But then also will pull in the institution's formulary. So you're able to actually tailor your guidelines to very specific recommendations that are going to be meaningful to your frontline providers. And you can create these really for a host of different conditions. At VCU, we have comprehensive treatment guidelines, which encompass probably about 40 separate guidelines at this point, and they're available on our intranet site, but also as a mobile smartphone application, and are available to our providers that way. Now, you don't need to do that sort of thing to have a major impact. If these things are available at the point of care, then they will be of value. Again, you're going to want to pull in your frontline clinicians when you're creating these guidelines, and then you're going to want to monitor sort of how often they're being used, and then their impact to frontline providers. This is an example of one of our meningitis guidelines for our antibiotic guide. And then moving forward, talking about the antibiogram. Antibiogram data is critical for informing local empiric antibiotic use. And again, this is really why there needs to be a very strong partnership between stewardship programs, their microbiology laboratories, and their information technology services. Now, antibiograms, just in a nutshell, typically these can be done in different ways. Usually facilities get these at the facility level, which encompasses about a year's worth of data looking at specific organisms and drugs, looking at resistance across a population of organisms for that year. There's different ways to do this. If you are able to, you can get very much more nuanced data down to the unit level. You can do it for more discrete time periods. The more nuanced, the better, with the understanding that if you have too few isolates, it's difficult to draw inferences from what you're seeing. However, these can be of enormous benefit when you are creating local treatment guidelines. One example, so if you see that your E. coli population has 25 to 30% fluoroquinolone resistance, those probably aren't good agents to be using when your providers are doing prostate biopsies, for instance. That means, over 1 in 4 of the patients who are receiving this are not receiving adequate antimicrobial prophylaxis. As you see shifts in your antibiogram over time, this will affect what you choose to use for prophylaxis, but then also for empiric treatment of various conditions, including sepsis. So again, antibiograms are very important. Now, when we look at the untoward effects of antibiotics, to summarize, mandates are here, and they represent great opportunities for programs to advocate for resources, especially FTE support or monetary support for physicians and pharmacists is crucial. All providers have a role to play with stewardship, however. Frontline providers should be aware of how dire the resistance crisis is and adopt some of the techniques that stewardship programs are providing for them. Some of those could involve the utilization of local treatment guidelines, partnering with stewardship programs to address specific issues, those sorts of things. But beyond this, frontline providers should take an antibiotic timeout really daily, but at a minimum of every 48 hours to ask what is being treated and what should the duration of therapy be, and can I de-escalate therapy? These should be questions that providers are asking for all of their patients receiving antibiotics daily. And again, the frontline provider should partner with the stewardship programs to address antibiotic use and resistance. So in conclusion, antibiotic resistance crisis is real and is getting worse, especially for gram-negative organisms. If we don't change our approach to antibiotic prescribing, these life-altering drugs will not be available to many of our patients moving forward. And we all have a role to play in optimizing antibiotic use and reducing the emergence of resistance, not just people that are active participants in stewardship programs, but especially frontline providers.
Thank you, Dr. Stevens. So now that everyone has completed the review of the resources and you've listened to this awesome recorded education, you're ready to complete the post-test. Click on the green icon to the right, the one with the pencil, and complete your test. Once you've passed the post-test with a 70% or higher score, you will receive a certificate for credits in your email within a week. We appreciate that you have taken advantage of this education and hope that it will help you in your practice.